Good morning. I believe it's too early to speak on a so difficult in certain ways subject. For me, it's too early to speak on that. So for you to hear, it will be even more difficult. What we three of us to address today is this conjunction of two important mechanical things that can happen to the lower urinary tract system in women. Underactivity, whatever that might be, and bladder outlet obstruction in women. Is it a new syndrome? Are they linked together? And how can we measure these parameters? Let me present the speakers. This is me, sorry. Don't I have a pointer or so? Okay. Professor Paulo Rodrigues, of São Paulo, director of Neurology Hospital in São Paulo, and Dr. Miguel Silva Ramos is a researcher on lower urinary tract function in University of Oporto in Portugal. Why we feel that this bladder outlet obstruction in females is a growing problem. It's, of course, an ancient problem, but for some reasons, it is becoming more frequent. And I think that we are becoming more frequently aware of that. I think that's the main difference. For us urologists, and we three are urologists, male obstruction is far better understood because of the prostate. Because not only of the prostate, but because men can describe very well their symptoms, their stream, the strength of their flow, and women cannot. Not only because they lack a prostate, women, and not only women, but also their doctors tend to forget that voiding phase, the emptying phase of micturition, and any symptom that women have are usually explained by storage symptoms, by inflammatory reasons, by urinary infection, or even by psychic mechanisms. Indeed, women fail to describe and to compare their stream with the past and to each other. Most in all over the world, every man, when they were in school, used to participate in contests. So we always know if a man, no matter how old he is, how adequate was his flow, his stream in the childhood. We can never say that and know that about women. Women are always concerned about if they leak or they do not leak, concerned about incontinence, and never concerned with urinary retention. So urinary infection is to blame for all symptoms. And indeed, urinary infection can be as well present. Incontinence in women, so there are new facts now. Incontinence in women has been very objectively studied by urodynamics investigation in these last decades. So we found some pressure problems, and we diagnosed in some women were suggesting a urodynamic diagnosis of something else than incontinence. That we tried to described as voiding dysfunction. Voiding dysfunction is very difficult to define. Voiding dysfunction still lacks a standardizing definition, but we are working on that. And very often in these incontinence women, we see not only increased resistance, but also, and more recently, recognized this entity that we may call it, for now, the underactive bladder. Or, if you prefer a more manometric and more urodynamic term, the underactive detrusor. Even though this underactive something lacks an adequate definition. More new facts. In the last decade, we did hundreds of thousands of procedures, of new anti-incontinence procedures that are well known, not meant to, but known to produce some increase in bladder outlet resistance. And since these anti-incontinence surgery are have so good results, any unsuccessful outcome must be thoroughly explained, even by ethical and legal reasons. So nowadays, I believe that this detrusor function first, and the urethral resistance, by other words, detrusor bladder performance, and bladder outlet obstruction must be measured objectively by numbers. Pure obstruction, you know, is rare, very rare in women. The fluid dynamics of the female bladders is more diverse and wide-ranging than in men, because when we see an urodynamics tracing, we never understand if the patient has 20 years of age or 60 or 80. But most often in a urodynamics tracing of a female, we can easily recognize if the patient has 20 years of age or 80. So, and not only the age is important, people with lower urinary tract symptoms, people with incontinence, women with incontinence, women with obstruction by urethral stenosis, or by prolapse of pelvic organs, they all have different fluid dynamics. Men are more alike. Either they have obstruction because of their prostates or urethral stenosis, or not. But the problem here is that the women are very wide-ranging in their fluid dynamics. So these boundaries of what is normal and what is not are less defined. You may know many male nomograms that can draw a clear boundary between what is normal, what is equivocal, and what is not normal or obstructed. So we need for women this standard of measurement, and we need it fast. Today we'll try to depict the causes of women voiding dysfunction, explore the clinical features, some historical survey of these diagnostic approaches to women obstruction and nomograms, present what data is available to us in these last 2 or 3 years in the known publications, and to propose and walk around the physics and the maths of these phenomena, and so realize the difficulties we have in these urodynamics, in female urodynamics, and understand its limitations and propose adjustments to the known nomograms and suggest practical things that can be used in our clinical practice. Well, just in a few minutes, you know the etiologic factors. There are new and old causes. Of course, the old causes are anatomical or functional. We know that. Is there any association with hyperactive detrusor? Cause or effect? Maybe, maybe both. Maybe both. The anatomical are still the same. Masses, incontinence surgeries, I think that could be underlined, incontinence surgeries. These are the new causes, and the urethral stenosis, etc. The functional causes are more difficult to explain. And as you can see, since Dr. Shlomo Ras in 1976 to Asnet Grautz and Bleivers in 2000 and something, there were lots of terms, different terms, since sphincteric spasms, pseudodyssynergia, neurogenic, non-neurogenic, the Fowler syndrome, etc., until the learned voiding dysfunction. That where it, for the first time, we speak about voiding dysfunction as a conjunction of something of undercontractility and obstruction. Learned because they felt that Dr. Bleivers and Grautz, they felt that these dysfunction could be learned out of many years struggling to hyperactive detrusor. But then in the next year, they changed this voiding dysfunction to an acquired and not just learned. Since women have no prostate and no cervical obstruction as we know them in men, there are more complex diagnostic algorithms, and many other things are in stake when we consider women. I thank Dr. Sakakibara this present year for his contribution. And also, and more recently, the relation of voiding dysfunction with prolapse of pelvic organs is now unequivocal. In these last years, Stefano, Salvatori, they showed very elegantly that vaginal prolapses can produce not only obstruction, but also difficulties in or interference in detrusor contractility. So, moving on, because I don't want to tire you in this first presentation, but this sling surgery-related obstruction or voiding dysfunction, this is the newest cause for sure. These people have very rarely acute urinary retention, but very frequently chronic voiding dysfunction, and we must be able to diagnose it because most often we cannot do it only by clinical grounds. We do not still know what is the effect of the tape on the urinary, on the outlet, but most probably there is is multifactorial, but the direct obstructive effect is a reality. And some authors have shown that. So, we have two concepts of female obstruction, or if you want, a bladder outlet obstruction, even for males. We have a manometric concept. This means that obstruction is described out of pressures and out of flows. It's a mathematical or physical concept of obstruction. But we have also an imaging concept, because by image we can see where the obstruction is taking place. My view is that the manometric concept is good to understand that there is an obstruction effect. The image can diagnose not the obstruction, but the site of obstruction or the type of obstruction, either anatomical or functional. Of course, video urodynamics makes the best of two worlds, because they give us the imaging and the manometric concepts. Most of the papers come from Ang, Short, and Kuo, and using video urodynamics, he found almost 10% of urethral obstruction in women, and he agrees, with me, I agree with him, that video is very valuable in localizing obstruction. You can see that example over there. These two women are obstructed, but in the first case, clearly with an open bladder neck, and this other case with a very, very closed bladder neck. These two patients, by the way, are not post-incontinence patients. I grabbed them out of my multiple sclerosis patients with dysnergias, and with video we can diagnose an external sphincter dysnergia and a cervical or proximal sphincter dysnergia, and this may have, of course, as you may understand, therapeutic, medical therapeutic implications. Obstruction and underactivity both coexist as a concept, a broader concept of this voiding dysfunction. By the way, in the document of Paul Abrams in the Standardizing Committee of 2002, the ICS definition, and it still is, we are working on that, but it still is this valid definition, is a contraction of reduced strength, but not only strength or duration, resulting in a prolonged bladder emptying, and of course a failure to achieve complete bladder emptying. That's redundant within a usual time span. So we have two notions now. It's the hypocontractility, reduced strength of the detrusor function, reduced detrusor performance. But the other notion is the shortness of contraction. So we can have a good detrusor contraction in a given moment, but this contraction is not long enough to achieve a good and complete bladder emptying. So I draw this scheme to show that every one of us, healthy people, male, females, cats, dogs, and everyone, is somewhere in between. Our lower urinary tract is somewhere in between the resistance and the detrusor power. Some people have more resistance, are more obstructed. Some others have less detrusor performance. So this voiding dysfunction has to be, we have to consider both and never isolated both the trusor failure or the trusor performance and outlet obstruction, or if you want, the urethral resistance. So underactivity interacts with obstruction and vice versa, that we cannot consider any one of these parameters independently. So my thesis will be today that it's pointless to have nomograms to diagnose underactivity, not taking into account the urethral resistance and vice versa. A obstruction nomogram must take into account the trusor performance as well. Wrapping up, we have a different from male, a female and dynamic and the fluid dynamics diversity, and if the bladder is what's the phrase? The bladder is a bad witness. The female bladder is even worse witness. We have growing iatrogenic causes, the anti-incontinence suburethral tapes. We have this broad concept, avoiding dysfunction, the binomial of the trusor performance and obstruction, and most of all, we still lack a consensus among us. We are working hard on that in the urodynamics committee and in the standardizing committee, but things are not that easy.